Good morning, everyone. I am Nitin, one of the spinal fellow at Leeds General Infirmary. The topic of my presentation today is, can we screw a lumbar spine without checking the pelvic parameters, especially at the single level fusion surgeries. So this is one of the paper with the longest follow-up for the single level fusions. And in this paper, the incidence of adjacent segment degeneration is 5% at 2 years follow-up, 9% at 5 years follow-up, and 15% at 10 years follow-up. The most common ASD is cranial ASD, which is around 77%. The caudal ASD is 13%, and the cranial as well as caudal ASD, the percentage is around 10%. The spondylolisthesis is the most common ASD. The stenosis is the second common, and herniated nucleus pulposus is the third type. So I have included all the articles about the importance of the pelvic parameters for the single lever lumbar fusion. There are total 14 key articles, most cited in last 22 years. So we can't speak anything about the single lever lumbar fusion without mentioning the Cloward. So Professor Cloward, he first did the PLIF surgery in 1943 without any instrumentation. He used the iliac crest to do the fusion. And his concept was, once a ruptured disc, always ruptured discs. So for all the discs, we need to fuse them. He's the surgeon who first discovered the ACDF surgery. He first did it, then chordotomy and the PLIF surgery. So all these three surgical procedures, he recorded the movies, and which has been filmed by the famous Hollywood photographer Billy Burke. He is the man who discovered the concept of the self-retaining retractor because he used to operate alone. We start our journal club with this case presentation. This is the 75 female with left leg pain and the back pain. At L4, L5 level, we can see the facetal arthropathy with stenosis, and at L5S1 level, there is a left-sided disc, extruded disc. So we did a L5S1 disc excision, and at L4, L5 level, the single level fusion with posterolateral fusion. And after 3 years, she came again with adjacent segment degeneration, and after 3 years, again adjacent segment degeneration at the proximal level. So she came to this, and then a thought came in my mind, like, will she need a fourth surgery? So there is some literature, like if there is a pelvic incidence lumbar lordosis mismatch of around 11 degrees, then in this patient, there is 75% positive predictive value that they will need a revision surgery. So for each 1 degree increase in the PILL mismatch, the odds of developing the adjacent segment disease increases by 1.4%. This is one more paper published a few years back, which says if the PILL mismatch is more than 10, then there is a 10 times more higher risk of adjacent segment degeneration, which needs surgery. So today we have selected this paper, the spinopelvic sagittal imbalance, as a risk factor for adjacent segment disease after single segment posterior lumbar interbody fusion. This is from the Japan, one of the university. Now why I selected this paper, because this is the first study to examine the relationship between the spinopelvic parameters and the ASD in the single level fusion, published in 2017. So till 2017, the radiological ASD, the incidence is around up to 36 to 84%, but the symptomatic ASD is up to 0 to 24%. The associated risk factors mentioned are age, sex, obesity, pre-existing degeneration, and the facet tropism. Surgery associated factors, the number of fused segments, disc height distraction, the method of fusion, and the lower lordotic angle of fused segment. So this is the first study. We checked the whole spine X-ray, and they checked the spinopelvic sagittal alignment by the whole spine X-ray, and they excluded all the other factors And this study is limited only to the L4 L5 fusion. So this is the retrospective study. They have included the 40 patients who underwent fusion surgery between 2005 to 2012. The exclusion criteria was presence of the scoliosis with Kopf-Zenger of more than 20 degrees. So total 20 patient, degenerative spondy in 18 patient, foraminal stenosis in 1 patient, and recurrent disc herniation in 1 patient. So the ASD occurred in proximal segment in 16 patients and the distal segment in 4 patients. The pathology for ASD was spondylolisthesis in 8 patients, which is most common pathology. Then the stenosis in 10 patients and the lumbar disc herniation in 2 patients. So they underwent PLIF in 11 patients, decompression in 7, and microdiscectomy in 2 patients. And they had this included the similar group as a control with 100 patients. So measurement, they measured the SVA, thoracic kyphosis, lumbar lordosis, sacral slope, pelvic incidence, and the pelvic tilt. The method of their primary surgery was the standard PLIF with 4 screws and the 2 cages at the single level, and posterolateral fusion was not performed at any level. So the result of this study is the revision rate of ASD according to the preoperative parameter. If the patient is having SVA of more than 50 millimeter, and if there is a PILL mismatch of more than 10, we're significantly higher in risk of ASD. The limitation of the study is a retrospective review of small number of patients. It was not possible to analyze all the risk factors for ASD that were previously reported. So to conclude, even with a single level PLIF, the appropriate segmental lordosis and lumbar lordosis should be obtained at surgery to improve global sagittal imbalance and PILL mismatch. Achieving the appropriate lumbar lordosis and PILL prevents ASD after the 4-5 PLIF. So while searching the literature for this paper, I came across few interesting facts. So this is the one of the study which shows that for the single level fusion, there is no need for rod bending, and you can put the straight rod, and with the straight rod also, if the adequate lordosis is achieved in the anterior column, then we can easily balance the patient. So this is the study published in 2021. It is a systemic review and meta-analysis, and which says that high BMI facet joint violation, anterior shift of lumbosacral sagittal plumb line, decreased lumbar lordosis pre-op ASD, and decreased pre-op adjacent segment disc height were significantly related to the ASD. And the indirect decompression and now minimal invasive surgeries, they lower the odds of developing the ASD. Even if you manage to get the appropriate pelvic parameters, the preoperative small SVA and thoracic kyphosis with the small PI, where the characteristic alignment for the risk of early onset ASD. So these patients are at more risk. So it's not always the pelvic parameter. There are other factors which are also associated with the ASD, that are increased age, degenerative spondylolisthesis, and fusion extended to the S1. Does the approach matter? So till date, the ideal surgery to achieve the adequate lordosis is the ALIF surgery, where you can improve the PILL mismatch. And this is the one more factor, like a screw length. If your screws are longer, as shown in the left X-ray, if your screws are longer, there is a much possibility that you will be able to restore your lumbar lordosis. So deeper the screw depth is within the safer range, the better the spinopelvic balance may be restored and the better the quality of the life may be. So there is some comparison between the cortical screws and the pedicle screw, but there is no difference between the fusion, but there is no study comparing the pelvic parameters restoration of the cortical versus pedicle screws. So the take home message is, next time before screwing any lumbar spine, get your X-ray of whole spine and make sure that you are restoring the PILL and SVA. Thank you.